So, hello everyone, I am Andrea Kate Cartusiano and I will be presenting now the schematic diagram of the pathophysiology of the disease process of the congestive heart failure. But before that, I just want to give a heads up that maybe throughout in this video, in my part, I will not be shown on the screen. Thus, I will be speaking behind the screen because I have some technical problems. I cannot do video and then video myself and then put the PowerPoint presentation together. I can just choose either one of the two. So, but rest assured, I will be speaking behind the PowerPoint presentation. I will be the one speaking, and I will be the one explaining. So, without further ado, I will be now sliding my PowerPoint presentation about the schematic diagram, the pathophysiology of the congestive heart failure. On the schematic diagram of the pathophysiology of the disease process of the congestive heart failure. So as you can see in the picture, it's all quite blur because it is the rundown or the smaller version of the schematic diagram. But later on, I will be flashing the whole diagram in a while. Okay. Okay, so here we are now at the schematic diagram. So let's zoom in and let's start. So our disease process is focused on congestive heart failure. So let's talk about the etiology of congestive heart failure. So as we all know, etiology means from the word means the cause or the set of causes or manner of causation of a disease or condition. That's according to the dictionary. So here, let's talk about why a person may develop this specific disease process. So causative reason behind this disease process may be physical inactivity or sedentary behavior. So as we all know, a sedentary behavior and physical inactivity are among the leading modifiable risk factors worldwide for cardiovascular disease and all-cause mortality. So it's not just about the congestive heart failure, but other things too. So it's according to a research, and the predisposing factors and precipitating factors also talks about specific areas in which this disease process can develop. So as we all know, just a background that our predisposing factors are all about the factors or the event that exist prior to the onset of a particular outcome. For example, here, as we can see, the first predisposing factor is family history of coronary artery disease or the genetic side. So this congestion can affect the pulmonary and systemic circulation, and then furthermore, coronary artery disease can be genetically inherited, of course. Predisposing factors, these are also non-modifiable. So for example, there is a hyperthyroidism for our patient. So our patient have excess thyroid hormone of their T3 and T4. So it results in high cardiac output and left ventricular hypertrophy, leading to congestive heart failure. So later on the lower part, we'll be talking more about that, or like touching about that in the disease process. But let us move on to the next predisposing factor. We have valvular heart disease. So valvular heart disease is the disease of one or more valves in the heart contributes to the development of congestive heart failure. So still genetic side, hypertension, increasing the workload of the pumping mechanism of the heart and promoting fluid retention. So hypertension is one of the most outlooked predisposing factors of congestive heart failure for most people, specifically based on research, people on the third world country, because they tend to not think of hypertension as something serious. Hypertension alone, when they have a consecutive high reading of blood pressure. So mostly they would say, that's just okay, ngayon lang yan, and etc., not knowing that in the long run, the heart may be really damaged by the uncontrolled high blood pressure. So it's one of the overlooked predisposing factors. And of course, we have age. So geriatric clients, of course, natural structural changes in our body as we age. There is an increased systolic blood pressure, there is increased ventricular wall thickness, and then there is increased myocardial fibrosis. But as long as as we age, we all know that our body goes through aging process too. So that's one of the predisposing factors. Or D, also non-modifiable or non-modifiable factors that a person may develop, or reason that a person may develop a congestive heart failure. And next is the precipitating factor. So these factors are series of events or conditions that act as triggers. So trigger meaning bringing the occurrence of a specific outcome. For example, here we can see cigarette smoking, substance abuse, alcohol abuse, obesity, nutritional deficiency. So those factors are modifiable. So in short, just so precipitating factors are those modifiable factors that we have. So we all know that cigarette smoking, substance abuse, alcohol abuse, obesity, and nutritional deficiency, it do have an effect in our heart. This may seem like these factors may seem like small in a period of time, seems like a small thing in our everyday living, but when we do this every day in a matter of time, it will pile up and pile up. So specifically in the alcohol abuse and the obesity, so there's no shame being a bigger person, but we're really looking into the how healthy the heart can be in a specific weight. So we should also take serious regard with these precipitating factors. So now that we've covered the upper part, as you can see in the diagram, the upper part, the etiology or the causes of this possible causes of this disease process, let us know the disease process and how it can be diagnosed first. Let's put the disease process later on at the last part. Okay, so according to American Heart Association, they classify congestive heart failure as stage A, B, C, D. Again, according to American Heart Association, they classify the congestive heart failure disease as class A or stage A, B, and C, and D. But however, the most used classification, again, the most used classification of congestive heart failure is the New York, is according to the New York Heart Association. So class 1, 2, 3, and 4, these classes, we base it on according to the New York Heart Association. So because this is the most used, of course, but we also have like stage A, B, C, and D from the American Heart Association. So there is a lot of also websites or association that we can base these things to. Okay, so the level of classification, class 1, of course, this is mostly asymptomatic, meaning there is no limitation of physical activity. Ordinary activity does not cause like undue fatigue or palpitation or even dyspnea. Then characteristic is that hypertension, so it may only arise as hypertension or high BP or blood pressure, atherosclerotic disease, diabetes, metabolic syndrome. So these are class 1. Class 2, we have mild. This also may be called as mild CHF. So it has slight limitation of physical activity. Of course, the patient may be comfortable at rest, but when ordinary physical activity is done, it could cause fatigue, palpitation, or dyspnea on their end. So the characteristic is history of myocardial infarction, left ventricular hypertrophy, and low ejection fraction. Class 3, or the moderate, it is marked as the limitation of physical activity. This is where we can see that our patient might be comfortable at rest, but less than ordinary activity causes fatigue, palpitation, or dyspnea. So the characteristics: shortness of breath, fatigue, decreased exercise intolerance. And this is where our patient comes in. As we could remember on the given scenario or the case, our patient was diagnosed with class 3 congestive heart failure. So here at the characteristics, we can um, really know, because the patient, as we can remember, exhibit this shortness of breath or dyspnea, and also he explained that he now have fatigue and decreased exercise tolerance, that before he can walk far far places, but now he can only walk in a near or very short distance, and then he would catch his breath frantically. So you can really see how our patient would be classified in here. Okay, so next is the class 4, the last class. It is characterized as the severe. So wherein the patient is unable to carry out any physical activity without discomfort, and then the symptoms of cardiac insufficiency at rest if any physical activity is taken, the discomfort is of course increased. So characteristics, symptoms despite maximal medical therapy, and of course there's recurrent hospitalization on the end of our patient. So now that we know like the level of classifications for congestive heart failure, let us also like review how do we diagnose congestive heart failure, because on the last videos or the last slides, also my group mates was able to explain what is congestive heart failure, right? So let us now proceed with how can we diagnose this congestive heart failure. As we all know, based on the meaning of the disease, so it's all about the heart, but so our diagnostic procedures will be more focused for the heart. So let's just zoom in. Okay. So the test is blood test. So blood test can also help diagnose. It can look for a specific protein by the heart and blood vessels. And then chest x-ray. So it can show the condition of the lungs and heart, if there is an enlargement of the heart, or if the lungs is free of any fluid, it can be shown in the x-ray. ECG or electrocardiogram. So it is a test record that is sends electric signals in the heart. So it really show how fast or slow your heart is beating. Then echocardiogram, sound waves that create images of the beating heart. So this test shows the size and structure of the heart and the valves and blood flow through the heart. And of course, EF, ejection fraction. So it is a measurement of the percentage of blood leaving your heart every time it squeezes. The measurement is taken during an echogram. So it classifies heart failure and guides the treatment. So there's a note here that 50% or higher is considered ideal, but you can still have specific heart failure even if the number is considered ideal, because later on we will talk here on the disease process. What are the types or other reasons of congestive heart failure? Of course, we have exercise test or stress test. So it involves walking on a treadmill, and then the heart is monitored as you exercise. So it shows how the heart responds to physical activity, right? If you can't exercise, you might be given medicines if ever, so that you can just see how this heart works when it is stressed. CT scan, of course, this uses x-rays, cross-sectional images of the heart. Can clearly see how the large is enlarged, or if there is hypertrophy on the heart and the valves. Then heart MRI scan or cardiac MRI. It uses magnetic fields, of course, and radio waves to create detailed images of the heart. Sorry for the typo here, it needs space. Okay. And next, coronary angiogram. So this helps spot blockages in the heart arteries, where the healthcare provider inserts a long, thin, flexible tube called a catheter into the blood vessel, usually in the groin or wrist, and then it guides it to the heart. So there's a dye used to follow through the catheter to arteries in the heart. this dye helps the arteries to clear or to be shown up clearly on the X-ray images and video. And lastly, myocardial biopsy. So this test is done by the healthcare provider, where they remove very small pieces of the heart for examination, and this test may be done to diagnose certain types of certain muscle diseases that cause heart failure, of course. So references here, by the way, the references of these things are written here at the lower part. So, okay, now onto the big chunk of our schematic diagram. Of course, the disease process of congestive heart failure. So we will be knowing more. Okay, let's proceed without further ado. Let's do this. Okay. So the disease process. So this disease process is referenced. Let me see here. Is referenced from Kiambao Udan 2023 in his book Medical Surgical Nursing Concepts and Clinical Applications, specifically on the congestive heart failure chapter. 4th edition, page 384-387 essay. Okay, so this is according to his book, specifically from the classification down to the signs and symptoms. It's in his book. Okay, so let's talk about these two classification of heart failure. We have backward and forward. So when we say backward, it's all about the right-sided, and when we say forward, it's all about the left-sided. So let's talk first on the left-sided congestive heart failure. Why? We want to talk first on the left-sided congestive heart failure because most reason why there is a right-sided congestive heart failure, when it happens, the right-sided, it's always because the patient have an underlying condition, or they already have a left-sided congestive or problem already in the left side. So let's tackle first about this left-sided congestive heart failure, or LSCHF. So let's see, let's zoom a little bit. Might be too small. Okay, so causes here is myocardial infarction, hypertension, aortic stenosis and insufficiency, and mitral stenosis or insufficiency. So as I've said earlier, hypertension is one of the overlooked causes of CHF, or congested heart failure. So it's really important, and it's really noted here that when our patient have this underlying conditions, of course, what happens to our heart is it has reduced myocardial contractility, so it can contract properly, and then increased cardiac workload. The reason for increased cardiac workload, because the heart can't contract properly, so there would be remaining blood on the heart. So when it opens or dilates to prepare for another contraction, there's an increase of there is a remaining blood, so there would be another blood that would fill it up. So there's an increased cardiac workload for the heart to do, because there is some blood that was left behind because of the reduced contractility. And what happens is that there is also a decreased diastolic filling, so, and an obstruction of the left atrial emptying. So there's an obstruction because of those blood that fill up the heart, because it cannot contract properly, and it cannot fill it. It has decreased diastolic filling. So when that happens, happens, of course, the pressure on the left atrial increases. So what happens when that pressure increases? There is what we call now a left-sided CHF, or congestive heart failure. So first is the stroke volume. When that happens, our stroke volume decreases. So how our heart can pump blood. So with that, there's a tissue perfusion, and when there's a tissue perfusion, what? There is a increased cellular hypoxia, because our blood is not pumped properly, thus it cannot oxygenate our muscles properly. So there is an increased cellular hypoxia. In a cellular level, our blood cannot properly oxygenate our muscles because there is a decreased tissue perfusion. Now, with the lacking tissue perfusion, there is also a decrease in blood flow to the kidneys. So what happens when there is a decrease to the blood flow to the kidneys? So we have the RAAS stimulation. So RAAS stands for renin, angiotensin, aldosterone system. So this system, this RAAS system alone controls the blood pressure and the fluid volume of our body. So let's just focus first on RAAS. So RAAS, what happens? Lower blood flow to the kidneys. So what happened? To compensate, our body releases renin. Specifically, renin is released from the kidney. And then, after that, our liver also releases angiotensinogen. So with that angiotensinogen, our lungs now would also release angiotensin 1. Angiotensin 1. 2 would also release angiotensin 1 or ACE. The ACE is released by the lungs to help control the angiotensin, to help convert angiotensin 2. So when angiotensin 2 is produced by the body, what happens in our body is that we have vasoconstriction and aldosterone release. So aldosterone is mainly the culprit for salt and water retention of our body, while vasoconstriction is the main culprit for increasing the blood pressure of the body. So again, if there is a low blood flow to the kidneys, RAAS stimulation will follow. RAAS stimulation is renin, angiotensin, aldosterone system. So when there is a renin release from the kidney, also the liver would release angiotensinogen, and the angiotensinogen will be converted to angiotensin 1 by the help of the lungs, because the lungs will release ACE to help convert angiotensin 1 to angiotensin 2. And when angiotensin 2 is released, we have vasoconstriction and aldosterone release. Vasoconstriction is much more focused, or the culprit behind increasing blood pressure, and aldosterone is the culprit behind water retention of the body. So as you can see here, vasoconstriction and reabs, if there is a RAAS stimulation, there is really vasoconstriction and reabsorption of salt and water. And when that happens, our ECF volume increases and our total blood volume increases. And when that happens, of course, our systemic blood pressure will increase. Because, as we can remember, RAAS, or the renin-angiotensin-aldosterone system, is the culprit or the system behind controlling our blood pressure and fluid volume. So that's to remember. So this is alone when the stroke volume is decreased. So now let's say our stroke volume is still the same, but because of the reduced myocardial contractility and the increased cardiac workload, decreased diastolic filling, and obstruction of the left atrial emptying, our blood dumps back into the pulmonary capillary bed. So we can imagine, so our blood is in the heart. So it tries to contract, but it has decreased cardiac workload. So there's a blood left still from the past or from the last contraction. So the next blood that would enter, and then they would like fill up the heart, and then until such time that it overflow. So where does it overflow? We're talking about the left sided CHF, ha? So where does it overflow? So when the blood overflows, it comes back to the pulmonary capillary bed. So as we can remember, it's on the lungs. So the pressure of blood into the pulmonary capillary bed increases because the blood backs down to the lungs. So what happened? So fluid shifts into the intraalveolar and interalveolar spaces, causing what? Edema, pulmonary edema. So as we can remember, our patient do have ascites, and there is also noted pulmonary edema. So that's one of the reason for his pulmonary edema is because his heart was not able to pump the blood out of the heart. So as time passes by, so the heart fills up with blood, and then the blood overflows to the pulmonary capillary bed or the lungs. So that's why having pulmonary edema, the signs and symptoms to look out for that is, of course, just to note, we have signs and symptoms. Signs is for the patient, on the patient side. How can they see, or the manifestation of the disease on the patient himself? While when we say symptoms, is the manifestation of a disease that a physician or the doctor or the clinical healthcare workers having the clinical eye perceives. So when we say the signs, we have dyspnea, paroxysmal, nocturnal dyspnea, orthopnea, Rayleigh crackles, moist cough, blood tinged, frothy sputum, wheezing if they're cardiac asthma, dizziness, and syncope. So that's what our patient would explain to the healthcare provider. But on the other hand, the healthcare provider would see symptoms of fatigue, weakness, anorexia, hypokalemia, specifically increased levels of aldosterone, because as we can remember, aldosterone is the culprit for this one, reabsorption of salt and water. That would lead to high systemic BP. Okay, next is symptoms is clubbing of fingers. S3 and S4 heart sounds. So S3 happens when this S3 and S2 heart sounds happens when, of course, our patient have this specific problem. So again, our S3, S4 heart sounds are heard when our patient have specific problems in the heart. So again, the difference of S3 and S4 heart sounds is that S3 is heard in the early phase of diastole, while S4 is in the late phase of diastole. So both of these S3, S4 heart sounds are common for patients with CHF. So it's supposed to be only S1 and S2 because lub-dub, right? But when our patient have problems with the heart, these other two can be heard. So there's a picture here. So as you can see, S1, S2, then we have S3 here, early, and the late diastole, S4. So that's the symptoms that the physician may observe, or any healthcare worker. We have also pulsus alternans and elevated PAP, PCWP, LV, EDP. So that's basically for the left atrial pressure. So, or left-sided, or the left-sided congestive heart failure, or the forward congestive heart failure. Okay. So right-sided congestive heart failure, again, just what I've said earlier, one main causes of having right-sided is when our patient already have this LS-CHF, or the left-sided congestive heart failure. And also, when they have pulmonary embolism, right ventricular infarction, and congenital septal defects. For example, like hypertrophy. So this one of the congenital septal defects. So when that happens, when these causes happens, our body or the heart may have reduced again contractility, increased cardiac workload, decreased diastolic filling, and now, of course, right atrial emptying tayo. So when it happens, also of course, right atrial pressure increases. What happened? We have right-sided congestive heart failure. So when we say right side, when we review the anatomy, so on the right side of the heart, the blood comes from the blood vessels. So, um, from the superior vena cava and then the inferior vena cava, right? So when our right side, when the patient have right-sided congestive heart failure, there is a decreased contractility, and just like on the left-sided, the blood comes back up because the heart is slowly over time fills up with blood. So where does the blood overflows now? So it dumps back from the right ventricle to right atrium, and then when that happens, there is a pressure of blood into the pulmonary capillary bed. So it increases. And when that happens, there is an increased pressure in venous circuit or venous backup. And then when that happens, the following signs and symptoms will manifest. So again, the blood dumps or overflows back to the blood vessels of the patient. So we have the inferior and superior vena cava, right? So there is a specific test. So neck vein engorgement or the jugular vein distension, for example, our patient. So their jugular vein is very distended when they have this CHF, hepatomegaly, and then portal hypertension, of course, cardiac cirrhosis, ascites, which is very present with our patient. Why does ascites happen? Because the blood is being distributed in the blood vessels of the patient, and then what happens is that the abdomen part of the patient will be filled with fluids, so that's why ascites happen. Then we also have splenomegaly, hemolytic anemia, internal hemorrhoids, of course. Then S3 S4 heart sounds also will be heard, then elevated CVP reading. Then the symptoms or wherein what the doctor would uh, observe is our patient will have peripheral edema. Of course, it can be pitting or dependent. So, which is very present also with our patient, and then jaundice and leg varicosities, and of course weight gain. Weight gain from what? From the um, uh, uh, water and salt retention, and of course from the blood that is being um, uh, that has been um, backing up to the venous circuit and to the pulmonary or in the lungs. So blood can back up on those areas, so in the lungs and in the abdomen part of the body. So this is the disease process of the congestive heart failure. A lot happens in the disease process of congestive heart failure, and as I've mentioned earlier, the body will always let's see. Okay, the body will always try to compensate through these changes. We can remember that the body strives to have homeostasis, right? So with those process also, they can also damage other organs and such, right? So one of the common things that they say when the patient have a congestive heart failure is they may also damage their liver. Why? Because the body tries to always compensate. As we can remember, the liver would release the angiotensinogen, right? And when our patient also is in medication for CHF, the liver would be the one who would filter and everything, and kidneys also, and the lungs will be damaged. So in this disease process, we have general management. So to combat those things. So the general management I've put here general management because it's not just for the nursing, but it's also better for us to know what are the pharmacologic, the nutritional, and the additional therapy we can offer to our patient, or we can learn to offer, or learn for the best of our patient. Okay, general management, we have medical management here. Okay, let's see. So the mnemonics of Dudband Clash is used as a guide. So it is a use, so it stands for digitalis, ACE inhibitors, dobutamine, beta blockers, oxygen nitrates, digitalis, calcium channel blockers, lifestyle changes, angiotensin 2 receptor blockers, sodium restriction, and hydralazine. So everything will make sense, or like some of the things will make like click on our head as we go over it, because we already learned the disease process. So ACE inhibitors, just what I've mentioned earlier, the lungs release this ACE to convert angiotensin 1 to angiotensin 2, which is angiotensin 2 would the primary or the reason behind vasoconstriction and aldosterone, which is also the culprit behind water retention and high BP. So when we give ACE inhibitors, this would block this ACE production, thus makes the patient in a like balance, or in a good health, or like that, like in a balance homeostasis part. Angiotensin 2 receptor blockers, as we all know, angiotensin 2, as I've mentioned just now. Beta blockers, so we have beta blockers also. So it reduce the adverse effects from constant stimulation of the parasympathetic nervous system. Diuretics too, as we can remember, we have water retention. Diuretics is used to lessen the water retention. Calcium channel blockers, so it causes vasodilation because angiotensin 2 causes vasoconstriction, right? So by this calcium channel blockers causing vasodilation, our systemic vascular resistance is being reduced. But of course, it is contraindicated with patients with systolic heart failure, I mean. So next is, of course, nutritional therapy. So nutritional therapy, we have sodium restriction and patient compliance. So sodium restriction, as we can remember also in the basics of our lessons before on biochemistry, where there is salt, there is water, right? Or where there is water, there is salt. So to lessen this thing to happen, because when there's water, when there is the presence of the two, so there's really also effect to the blood pressure. So our patient is being restricted with sodium or asin. So as we can all know, or observe in our grandmothers, or mga elderlies, they would not eat salty foods, right? Because that's what their doctor ordered. So it decreases the fluid retention, symptoms of peripheral and pulmonary congestion too. And of course, nutritional therapy, patient compliance. Because there are patients like saying, mukaon kog baboy, ay mukaon kog bawal, okay lang nabitay tambal. So that's one of the very basic management that we can remind of our patient, that to really comply to what the doctor said. If bawal, bawal. And if there is a maintenance of maintenance medicines is very also important to remind our patient compliance, that they really need to take those maintenance medicine, because there's a reason for those maintenance, right? Because as I've also mentioned, hypertension is one of the most overlooked what again? Predisposing factors of congestive heart failure. So they must be compliant to the therapy or the nutritional therapy that they were given, or the medications. So additional therapy, we may give oxygen, or cardiac resynchronization therapy, and ultrafiltration. So these are like other things for those we can give for those like severe class 3, class 4, right? Classification of CHF, or congestive heart failure. So now that we all learned the causes, the classification, the diagnostic here, the disease process as it is, the signs and symptoms that we can that the patient can perceive or can observe in himself or herself, and the symptoms that the signs that the patient can observe, and then the symptoms that the doctor or the healthcare worker could observe, together with the general management, of course, we can now therefore conclude here at the bottom. If the patient is left untreated, what happens? There is a prognosis of negative prognosis. So it may result to serious complications such as organ failure. Of course, most organs that will fail: lungs, liver, kidney. Those organs that really work hard to maintain homeostasis of the body. And then if really not treated, it may result to death, which is the severe or like the most um, uh, bad outcome one can get if CHF is left untreated. But if the family member and the patient would really treat or go for treatment, the prognosis or the expected outcome, of course, it increases chance of long-term recovery. We say long-term recovery or even extends person's life. So when we say long-term recovery, so the patient may enjoy more years or even um, able to, if ever, eliminate this congestive heart failure through different operations, right? Pacemaker, there's a transplant now based on recent studies of heart, right? They can have the chance of long-term recovery or even maybe extends a person's life depending on how long they want to. Some would like go for very drastic or exploratory treatment because they really want to extend their life in a longer period. So then it would happen because they do treatment. So that's the expected prognosis. So basically, our disease process here of congestive heart failure is um, a serious topic that one we can learn. And so by learning this specific disease process, we may be able to become a better nurse in the future, being able to make a lot of management that are more appropriate and applicable to the needs of our patients that are diagnosed with a disease process of congestive heart failure. So that's all for the um, schematic diagram of the pathophysiology of the disease process of congestive heart failure. And I will be passing the virtual floor now to the next reporter or my group mate. Thank you.
Now proceeding to the doctor's progress note, we have the date and time, which is September 5, 2023 at 8 a.m. The progress note is positive bilateral grade 2 plus edema on lower extremities with an abdominal girth of 35 inches and the O2 sat of the patient is 90%. For the physician's order, we have the following. Please admit under the service of Dr. Generalao. For the rationale, we have this is to establish a designated doctor to which all patient information regarding the patient will be referred accordingly. Monitor vital signs every 2 hours to obtain a baseline data and monitor the patient until stable. Strict input and output every shift because strictly monitoring for intake helps to ensure that the patient will have a proper intake of fluid and other nutrients, and also monitoring for the output helps determine whether there is an adequate output of urine as well as normal defecation of the patient. Now, weigh patient daily pre-breakfast, post void. Weight is one way to tell if your heart failure is getting worse or if you need changes in your medication to control extra fluid in the body. Now, for the diet, we have low salt, low fat. So, limiting sodium in diet will help minimize the amount of extra fluid around the heart, the lungs, and the legs. And It will also prevent heart failure symptoms from getting worse, like the feel build up, the weight gain, the bloating, and the swelling. And attached to oxygen inhalation at 4 liters per minute via nasal cannula, because attaching oxygen inhalation via nasal cannula is used to deliver oxygen when a low flow, low or medium concentration is required by the patient's need. Now, IVF PNSS 1 liter at KVO rate or keep vein open. These IV fluids will replenish the electrolytes, and a KVO infusion may reduce areas of stasis and risk of coagulation of the patient. Now we have the labs. The first lab is CBC, or the complete blood count. So this is a group of tests that evaluate the cells that circulate in the body, including the RBCs, the WBCs, the platelets, or like the RBC is the red blood cell and the WBC is the white blood cell. So the CBC can evaluate your overall health and detect a variety of diseases and conditions. Now for the BUN and CREA. So BUN means blood urea nitrogen and CREA is creatinine. So BUN is a test that measures the amount of urea nitrogen that's in our that is present in our blood, and the creatinine is used to see if our kidneys are still working normally. Now for the CXRPA, or chest X-ray posterior anterior, this test will help to visualize the structures of our chest walls, which will include the collarbone, the breastbone, the ribs, the shoulder blade, and the surrounding muscles of the chest wall. It also helps to visualize the internal organs of the chest, which also includes the lungs, the airways, heart, food pipe, and the diaphragm. Now, for the next lab, we have 12 lead ECG, or electrocardiogram. It is a medical test that is recorded using leads or nodes that are attached to the body. Now, for the serum electrolytes, specifically the sodium and the potassium. So, an electrolyte test will help to determine whether there's an electrolyte imbalance presence in the body. So, this will specifically focus on the sodium and the potassium of the patient. Now for the CBG, now then OD-ACBF, or the capillary blood glucose, then once a day before breakfast. This monitoring is a convenient way of monitoring blood glucose patterns and can be a useful aid in guiding treatment changes in the patient, with those patients who have type 1 and type 2 diabetes, especially during periods of instability. Now for the FBS, or the fasting blood sugar, it measures the blood glucose after the patient have not eaten for at least 8 hours. It is also often the first test done to check for pre-diabetes and diabetes. Now for the lipid profile, a lipid profile test is used to measure the amount of good and bad cholesterol and triglycerides in the blood. Now, for the UTZ whole abdomen, or the ultrasonography of the whole abdomen of the patient, this is used to look at the organs in the abdomen, including the liver, the gallbladder, the spleen, the pancreas, and the kidneys of our patient. Now, for the BNP test, or the brain nat- natriuretic peptide, is a blood test that measures levels of a protein called BNP that is made by the heart and the blood vessels. Now for the meds, we have lisinopril 10 milligram once a day per ORM, or by mouth. So this works by blocking a substance in the body that causes the blood vessels to tighten. So as a result, it will relax the blood vessels, then it will lower the blood pressure and increase the supply of blood and oxygen to the heart of the patient. Now we have carvedilol, 12.5 milligram, one tab BID, or twice a day per ORM. So This decreases the myocardial work by reducing all three components of myocardial oxygen demand, namely the heart rate, the contractility, and the wall tension. Now for the metoprolol, 25 milligram, one tab, twice a day per RM. So this is used with or without other medications to treat a high blood pressure or hypertension. So lowering high blood pressure helps to prevent strokes, heart attacks, and kidney problems. And furosemide, 40 milligram, one tab, twice a day per RM. This will reduce extra fluid in the body or the edema caused by conditions such as a heart failure, which is the condition of our patient today, and the liver disease and the kidney disease. So this can also lessen symptoms such as the shortness of breath and swelling in arms, legs, and abdomen. Now we have spironolactone, 50 milligram, one tab, once a day per RM. This prevents the body from absorbing too much salt and keeps the potassium levels from getting too low. It also used to treat heart failure, high blood pressure, or hypokalemia, which means that the patient has low potassium level. So digoxin 0.25 milligram once a day per RM helps an injured or weakened heart pump more efficiently. It also, excuse me, it also strengthens the force of the heart muscle contractions, helps with restoring a normal steady heart rhythm, and also improve the blood circulation of the patient. It also used to treat heart failure. Now for the metformin, we have 500 milligram once a day per RM. So this will help to control the amount of glucose in the blood. It also decreases the amount of glucose that the patient absorbed from the food that he ate and the amount of glucose made by the liver of the patient. And then lastly is relay result once in. So this will help monitor and properly evaluate and administer the appropriate care which the patient needs. Now for the September 6, 2023 at 12 noon, for the progress notes, we have uh, serum sodium, which is 130, and for the serum potassium, which is 3.3, and a positive abdomen pain of 3/10. Now we have the um, physician's order, the schedule for 2D echo in AM or morning. So scheduling for 2D echo is used to evaluate the functioning and assess the section of the heart. It also excuse me. It also creates images of the various parts of the heart using sound vibrations and makes it easy to check for damages, blockages, and blood flow rate. Now we have to start Durol, one tab once a day per RM, because this will prevent potassium loss or replaces potassium loss by the body. And aspirin 80 milligram, one tab OD PC lunch. And this aspirin thins the blood, which helps prevent the blood clots from forming. And then we have losartan 50 milligram, one tab ODPO. It is used to treat high blood pressure and used to lower the risk of stroke in certain symptoms such as heart disease, which is the patient is experiencing right now, the heart failure. And simvastatin 20 milligram, one tab ODPO at 8 p.m. This will work by slowing the production of the cholesterol in the the body, to decrease the amount of cholesterol that may build up on the walls of the arteries and block blood flow to the heart. Now we have to place the patient on MHBR, or the moderate high back rest, to reduce the congestion in the lungs So the patient must keep their upper body elevated, and this will help to overcome breathing problems since it will allow lung expansion. Now, for the O2 sat monitoring every 4 hours. So, by monitoring for oxygen saturation every 4 hours, this will help identify early hypoxia in patients and also evaluate the effectiveness of the oxygen therapy being administered to our patient. Now, we have to limit also the oral fluid intake to 1 liter per day because fluid restriction is needed if the body is holding water. Now, fluid retention can cause heart problems such as tissue and blood vessel damage, long-term swelling, and stress on the heart of the patient. Now, continue meds because compliance with medications will help prevent any complications that may happen to our patient. And then lastly, for the September 7, 2023 at 10 a.m., there is no progress notes. However, there is a physician's order. Now, to follow PNSS 1 liter at KVO rate because IV fluid will really help replenish electrolytes. And a KVO infusion may reduce areas of stasis and risk of coagulation. And then maintain oxygen inhalation at 3 liters per minute via nasal cannula because continuous oxygen inhalation will help to assist the patient in breathing properly, and this also increases the amount of oxygen sent to the body's tissues. And then we have to uh, demonstrate or instruct patients to do deep breathing exercises because breathing exercises will help relax and slow down the heart rate, as well as it will also allow the body to take in more oxygen, resulting in increased oxygen levels and to relieve pain when breathing. And then lastly, continue meds because again, compliance with medication will help prevent any complication that may happen to the patient.
Hello everyone, I am Chahara Gelgaman and now I am going to discuss to you the laboratory or the diagnostic examination results of the patient. For the CBC or the complete blood count, it is all normal. And for the chest x-ray, the cardiac silhouette was enlarged. There was a bronchial wall and coughing and prominence of the upper lobe vessels consistent with vascular redistribution and interstitial edema. The lower lobe vessels were also partially obscured due to the interstitial edema and possibly mild alveolar edema. Subpleural edema resulted in prominence of the lung fissures, small moderate bilateral pleural effusions were seen. The interpretation for this is cardiac silhouette enlargement with secondary findings of congestive heart failure. Next is for the electrodiogram or the ECG. It is essentially normal findings. For the ultrasound, a survey of the four quadrants of the abdomen was performed. The patient was scanned in the supine position. There are diffuse ascites within the right upper, right lower, and left lower quadrants. An X was placed on the skin within the right lower quadrant. The distance from the skin to the beginning of the fluid is 1.0 centimeter. The distance from the skin to the middle of the fluid is 3.9 centimeter. And the impression for this is moderate diffuse ascites marking place within the right lower quadrant. For the lipid profile, which is the blood test that can measure the amount of cholesterol and the triglycerides in your blood, the results for cholesterol is 245 milligrams, which is above average. The normal range for this is lower than 200 milligrams. And next is the triglycerides result is 350 milligrams, which is above average. The normal range for this is 10 to 150 milligrams. And then the result for the LDL cholesterol is 180 milligrams, which is also above average. The normal range for this are 70 to 130 milligrams. Next is the test for the basic metabolic panel. The sodium is below average, which is 130 liters. The normal average for this are 135 to 147 liters. For the potassium, the result is 3.3 liters, which is also below average. The normal average for this is 3.5 to 5.2 liters. And then next is the 2D echo test. It is a non-invasive test used to analyze the functioning and assess the sections of your heart. This test gives images of the different parts of the heart with the help of sound vibrations. It assists in checking damages, blockages, and blood flow rate. A normal 2D echo result will show that there's an absence of any malfunctions and a typical movement of heart structures. For the results of the patient, mild enlargement of left ventricle cavity, mild global left ventricular systolic dysfunction, indeterminate systolic dysfunction due to arterial fibrillation of or the flutter, and normal left ventricular wall thickness. The left ventricular ejection fraction is visually estimated at 47%, and the left ventricular ejection fraction is measured at 59%. Moderately dilated left atrium, so the rhythm during the study was atrial fibrillation at a rate of 103 beats per minute. No prior studies at this facility for comparison. And then lastly, for the BNP test, so it is a blood test measure the levels of a protein called BNP in your bloodstream. So the results for this is 950 ml, which is normal. So that's all for the laboratory and diagnostics examination result of the patient. Thank you.
Now, for my drug study, I have the name of the patient, patient X, age 79 years old, sex male, civil status, married, date of admission September 5, 2023 on room 303 with an attending physician of Dr. Henry Lau. So for the date ordered, we have September 5, 2023 at 8 a.m. The medications brand name is Lopresor with a generic name of metoprolol and a classification in pharmacotherapeutic beta-1 adrenergic blocker. And for the clinical, we have anti-anginal and antihypertensive. So for the mode of action, it inhibits the beta-1 receptor sites, which is located mainly in the heart of the patient. So this will slow the heart rate, decrease the cardiac output, and the myocardial oxygen demand, and also reduces blood pressure. So I have here the reference, the Hodgson K and Kizor R 2021 Saunders Nursing Drug Handbook, United States of America, Elsevier Incorporation. Now for the dosage, we have 25 milligrams, and the route is in per RM, and the frequency is one tab twice a day. So for the indication, it is used to treat angina or chest pain and also to manage hypertension. And this will be used alone or with other antihypertensive drugs. And also, it will help relieve symptoms of heart failure. And as you can see, this is a good drug for our patient because the patient is experiencing heart failure or is diagnosed with class 3 heart failure. Now, for the contraindications, we have it is contraindicated with patients who have hypersensitivity to the metoprolol and other beta blockers. And also, it is contraindicated with patients who have severe sinus bradycardia or like the heartbeat is slower than the normal heart rate and moderate to severe heart failure. And also, it is not for patients who have a heart block greater than first degree. Since if you have greater than first degree, if like for example you have the second degree heart block, then you may need a pacemaker to keep your heart beating. to as it should be. And for the side effects, we have the frequent side effects that the patient may um, experience. First is the diminished sexual function or the lack of sexual desire. And the drowsiness or like the feeling of sleepiness, the strong desire of like sleeping, like kanang gusto kay ka like mapili mo nga katugod kay ka, and the insomnia or like maglisod kag tulog, and also the unusual fatigue or weakness like kanang wa kasabot ka nang kapoy kay ka, weak kay ka, okay, so like that, like you don't have the energy, like nag-anak na jud ka, like that. And for the adverse effect, we have the central nervous system, we have CVA or the cerebral vascular incident, hallucination, anxiety. For the cardiovascular, we have the cardiac arrest, the arrhythmias. And for the gastrointestinal hepatitis, and for the hem, the leukopenia, which is a condition where the body doesn't have enough disease fighting white blood cells in the blood. And for the thrombocytopenia is the lack of platelets in the body, or I mean in the blood. And for the respiratory, we have the bronchospasm, which is the tightening of the bronchi or the airways in the lungs. Now for the nursing responsibility, first excuse me, we really have to verify any medication order and make sure it is complete. The order should include the drug name, the dosage, the frequency, and the route of the administration to um to promote safety administration of the drug to the patient. And also we have to check the patient's medical record for an allergy or contraindication to the prescription, because if there is, then we should not be administering this medication to the patient since it will put harm to our patient. And then next is check the patient's vital signs before and after drug administration. So we have so that we can have a baseline data or a comparison, which we could be able to observe, or we could check if there is any changes with the vital signs of our patient before and after the drug administration. And then educate the patient or the watcher about the possible side effects and how the drug works, because they should know so that they are aware of what the patient will be experiencing after after the drug administration, and also to know the purpose of why this drug is being administered to the patient. So this could also prevent any anxiety to the patient if they know the side effects as well as its purpose. Then we have to instruct the patient or the watcher to take metropolol with food at the same time each day, and inform the patient watcher or the watcher that they can have the tablet but not chew or crush the tablet. So only cut it into half but not chew or crush. And then assess for signs and symptoms of side or adverse effects and advise patient whether or watcher to report any adverse reaction so that we are able to document it or to notify the head nurse or the physician what with the condition of the patient, and also to uh, have a immediate response to the adverse effect that the patient is uh, experiencing. And then we have to check for signs of poor glucose control in patient with diabetes mellitus so that we can be able to respond with it if there is a poor glucose control. And then respond promptly and appropriately to severe or life-threatening adverse reactions, interactions, and complications that will happen to the patient. To promote safety and better health of the patient, and also so that we won't be um uh, we won't be like kanang i-worsen dili pa nato mas i-worsen ang condition ng patient if there are any adverse reactions. So we really have to respond immediately to any adverse reaction. Kay since na gani heart failure patient na niya nag-adverse reaction pa rin siya and yan dili ta mag kanang akta yun that it may lead to serious complications. And then lastly is the document drug administration so that we have in an evidence or we have a documentation that we had done um the we had done the administration of the drug. So that's all for
So, for the nursing care plan, as part of the nursing care plan prioritization, the nursing diagnosis that was chosen is decreased cardiac output related to impaired contractility secondary to congestive heart failure. So, our patient named is patient X, age is 79 years old, sex is male. Our patient's chief complaint is episodic shortness of breath for 2 weeks. Date of admission is on September 5, 2023, under the care of Dr. Henera Lau on room 303. So date and time cues. The patient is admitted on September 5, 2023 at 8 a.m. There were no subjective cues noted in the case. Objective cues, as manifested by the patient: shortness of breath, O2 saturation of 90%, respiratory rate of 28 cycles per minute, S4 heart sound auscultated, ballooning of the belly, grade 2 edema on lower extremities, weight gain of 8 to 10 pounds in the previous 6 weeks, as indicated on the laboratory results of our patient, mild enlargement of the left ventricular cavity, and last but not least, small to moderate bilateral pleural effusion. So we're going to discuss that one by one later. Next is for my final nursing diagnosis: decreased cardiac output related to impaired contractility secondary to congestive heart failure. So, in relation to the case of our patient, decreased cardiac output related to the congestive heart failure, our scientific basis for this is as follows. So, decreased cardiac output is the inadequate blood pumped by the heart to meet the metabolic demands of our body. So, when the patient has a congestive heart failure, your heart can't pump enough blood to supply your body's normal metabolic demands. So, as part of our patient's laboratory result, there is a mild enlargement of the left ventricular cavity. Um, in this, which has risk factors of diabetes as part of our patient's past diagnosis, obesity, and sedentary lifestyle. So this loses the ability of the heart to pump blood. So in reaction to this, blood and fluid will collect in your lungs and legs over time, and this causes edema on lower extremities, pleural effusions in the pleural cavity, thus decreasing the cardiac output and, as manifested by our patient, the shortness of breath. So, moving on to the goals and objectives. So, the goals and objectives is made by a SMART plan. So, it is divided into two: the short term goal and the long term goal. So, for the short term goal, our patient or our goal is that the patient will verbalize knowledge of the disease process, the risk factors, and the treatment plan. So we also need to stabilize the O2 saturation and the respiratory rate of our patient. We also need to see or to evaluate that the patient will report a decreased episodes of dyspnea or shortness of breath. And we also need, as part of our short-term goal, we also need as a nurse to administer the prescribed medications of our patient. Now, moving on for the long term goals, we need to ensure that the consistency of the medication is being followed, the medication management, the dietary and fluid management of our patient, and the activities that reduces workload of the heart. So for my nursing intervention, it is divided into three: the independent, the dependent, and the collaborative. So for the independent, it does not need a doctor's order or a doctor's collaboration. For the dependent, it needs the doctor's order. And for the collaborative nursing interventions, it needs the collaboration of healthcare professionals to meet the care or to meet the expected care of our patient. So, for the independent nursing interventions, first things first, we have to review the laboratory data or the diagnostic data. So, this diagnostic and laboratory data includes the complete blood count or CBC, the serum electrolytes, the ECG or the electrocardiogram, the X ray, and the abdomen ultrasound, and the echocardiogram of the heart. So the rationale for this intervention, this is to identify imbalances of the electrolytes, the disease process, and the desired adverse effects of treatments. So next, nursing intervention is to assess and monitor the vital signs of our patient. This includes the blood pressure, the heart rate of our patient, the respiratory rate, and the oxygen saturation. So these vital signs is directly connected to the diagnosis of our patient. So the rationale for this is to provide a baseline data for comparison and to follow the trends and evaluate response to certain interventions. So third is to keep the client on bed rest and elevate the bed in a position of comfort. So the position of comfort is the semi-Fowler's position. The semi-Fowler's position is de- uh, decreases the oxygen consumption and the risk of decompensation of oxygen. So it is the desired position for patients who have shortness of breath. So next is to assess and document the patient's fluid intake and output to monitor fluid retention or depletion. So for the rationale, um, this helps to guide fluid and diuretic therapy and to maintain optimal fluid balance to minimize dehydration and dysrhythmias. So we need to remember that when the patient is taking any diuretic medication, um, it is expected that the patients will pee a lot since diuretic removes water in her body. Diuretic medications removes water in her body. So the patient, in exchange, the patients will urinate a lot. So we have to assess that one so that we could prevent dehydration and dysrhythmias. Next is to elevate the legs when the patient is in sitting position. The rationale for this intervention is that elevating the legs in sitting position limits the venous stasis, it improves venous return and systemic circulation, and reduces the risk of thrombophlebitis as the patient is already experiencing edema. Edema also occludes the circulation, so it is important to elevate the legs. Next is to encourage changing of positions slowly and dangling legs before standing. So this is to reduce the risk of orthostatic hypotension, especially if heart failure is present. So for the dependent nursing interventions, we have to administer medications as ordered by the physician. So these medications include inotropic medication, diuretics, and any heart medication. So the rationale for this part is that inotropic drugs maintain the systemic perfusion and it preserves and organ performance. and as well as diuretics reduce congestion by improving urinary output and removing water in her body. So, next is to administer supplemental oxygen at 4 liters per minute as per doctor's order. So, supplemental oxygen increases the oxygen availability for cardiac function or tissue perfusion. So, last, number nine nursing intervention is the dietary changes such as low salt, low fat, as per doctor's order. So, we also need to provide education on a heart healthy, low sodium diet to help manage the fluid retention and the blood pressure of our patient. So, for the collaborative nursing intervention, we need to collaborate with a registered dietitian to assess the patient's nutritional status and develop a customized dietary plan. So, the dietary plan for a patient with congestive heart failure is the low salt, low fat, because the patient has already manifested pulmonary edema. So, dietitians can help patients manage sodium intake, the fluid restriction, and to achieve a heart healthy diet. So, next collaborative nursing intervention is to work with telemetry technicians and cardiologists to provide continuous cardiac monitoring for the patient. So, collaboratively assess and respond to changes as in the patient's rhythm, as arrhythmias can worsen the cardiac output. So, we need to collaborate with the technicians, the telemetry technicians, to furtherly assess the patient's heart rhythm and the patient's condition. So, the last but not the least, nursing intervention is to collaborate with the patient and their family about heart failure management, the medications or the consistency of medications being ordered, the lifestyle modifications, and the symptom recognition. So, it is essential or it is important for improving patient outcomes. So, this enhances their quality of life and this reduced the overall burden of this condition. So for my evaluation part, um, on September 5, 2023, as or after my 8-hour shift and 4 p.m., my evaluation goal is partially met. So we need to understand why. So after the 8-hour span of care for the short term, we have the patient's family. So patient's family verbalized the disease process. So as they said, factors said di ay ang weight gain, maong maglisod na og pump iyang heart, bantog pod maglisod siya og ginhawa unya nagapang hupong siya. So that was verbalized by the patient's family. So for the O2 saturation after 8 hours of care, the O2 saturation of our patient is now 93%, which has improved but still not on normal level. So also the respiratory rate is now 23 cycles per minute, which is not on the normal level but has improved. Next is that the patient can now talk slowly with a minimal shortness of breath or dyspnea. Next is that the medications such as metoprolol, furosemide, and medication that lowers the high blood pressure such as lisinopril, losartan are being administered as per doctor's order. So for my long-term goals, we have medication and treatment management are consistent with the patient, and the patient is still following the treatment plan and the proper positioning in cases of shortness of breath. So we also have a long-term goal or a long-term evaluation of input and output of patient is being monitored. The patient did not develop dehydration and fluid imbalance. So next last part is that the patient and the patient's family participates in activities such as the balanced diet, healthy diet, staying hydrated, maintaining a healthy weight, and avoiding heavy activities and promoting bed rest. So that would be all for my nursing care plan as part of the requirements for or the requirements of the prioritization of nursing care plan. Okay, so today, I'm going to present the FDAR as part of the prioritization plan. So the focus data action and response, the name of our patient is patient X, 79 years old, a male under the care of Dr. Hannah Rolao, admitted on September 5, 2023. So for the focus of our patient, we have edema or pulmonary edema. So the data or the objective data collected, the patient presents with significant grade 2 plus edema in both lower extremities. We have that the patient has gained 8 to 10 pound weight for 6 weeks. And we also have a data of the patient that has an oxygen saturation of 90%. So for my action, we have to administer prescribed diuretics to promote diuresis and fluid removal. So diuretics medication is a medication that promotes the removal of excess fluid in our body. So it is good for person or patient with edema. We need to elevate the patient's lower extremity regularly. This is to aid in venous return and decrease the edema. So edema occludes the circulation of our patient. So we need to elevate our leg or we need to elevate the legs of our patient in order to improve the circulation. So next is to monitor daily weights and fluid intake or output to assess progress. So since our patient is taking diuretics, so we don't want that the patient is dehydrated. So in turn, diuretics is a fluid removal medication. So in turn, um, the patient will urinate a lot. So we need to monitor their fluid and intake output to ensure that the patient does not exhibit dehydration. So next is to educate the patient on sodium restricted diet and fluid management. So the sodium restricted diet, this diet or the sodium restricted diet reduces your sodium intake or your sodium intake as the sodium intake is the primary focus to reduce the effects of edema. So um, this or the diuretics reduces the amount of fluid in the tissues, which in turn it reduces the volume of your blood that your heart will or that your heart has to pump. So it is an important intervention. So as part of that, we also need to collaborate with a nutritionist for the dietary plan of low salt, low fat diet. So after 8 hours of care, we have the response. So the patient experiences the gradual reduction in lower extremity edema. The patient reports an improved comfort. The patient also has improved O2 saturation of 93%, which is not on the normal level, but it has improved. So next is that the patient is now practicing a dietary plan of low salt, low fat diet to reduce swelling or to reduce pulmonary edema. So overall, the evaluation is goal met. So that would be all for my FDAR.
So for the clinical reasoning questions, you noticed that the patient was having shortness of breath while using the incentive spirometry at bedside. So you are asked by your clinical instructor to refer the matter to the staff nurse using the CUS as an assertive technique. What will you tell to the staff nurse? Answer narratively. So for the CUS, first I am concerned with the patient's condition while using the incentive spirometry at bedside. The patient is experiencing shortness of breath. Then for the U, I am uncomfortable because the incentive spirometry, which is supposed to encourage the patient to take slow deep breaths to improve the function of his lungs, doesn't accurately reflect the patient's current condition. The next is for the S, this is a safety concern since dyspnea and shortness of breath is frequently a sign of underlying heart and lung conditions, including asthma, pneumonia, COPD, congestive heart failure, and pulmonary embolism, which calls for quick medical attention to provide the necessary interventions. Then for the clinical reasoning questions, you have the ethical, moral, legal factors. So Dr. Sabido encouraged patient X to have follow-up testing and to take his meds on a regular basis in following discharge. So patient X informed Dr. Sabido that the prescriptions are expensive and that they would rather go for herbal treatments because they are more natural and less expensive. So aside from the meds, the patient does not want to go through any test because he is content with where he is now and has accepted his status. So, what will be your nursing action in this scenario? What ethical principle is applicable in this scenario? So, for the nursing action, so as a student nurse, we are taught to approach the scenario in a non-judgmental way. We need to assess the patient X understanding of their medical condition and the importance of medications and follow-up testing in managing their health. Aside from that, we must educate the patient on benefits of adhering to the prescribed treatment plan and the potential risk of not following it. So, moreover, addresses the patient X concern about the cost of medication and tests, then explore possible options for financial assistance such as insurance coverage, government programs, or pharmaceutical assistance programs. So we need to provide information on these resources and help the patient navigate the process if needed. Then for the ethical principle, first is the autonomy. So the nurse must respect patient X's autonomy while also providing education and support. So this is to help the patient make informed decisions about their care by addressing the patient's concern and exploring potential resources. So the nurse can help empower the patient to make choices that best align with their values and preference. Next is the beneficence. So our patient is our priority. We must always think of what is best for them by encouraging the patient to follow up testing and adherence to prescribed medications. Also, we should consider alternative treatments that may be more affordable while ensuring that they are safe and effective. Then the third is the veracity. So which is the act of truth telling. So this relays information needed by the patient and stating it with clarity and free of bias. So being honest to our patient when educating him about all the possible options he could have and the corresponding effects of his decision. So this is part of our responsibility as a student nurse. So let's proceed to the discharge plan. So in discharge planning, the nurse serves as the connection between inpatient and follow-up or outpatient care. So they assist in ensuring that the patient and their family are aware of what to do after discharge to avoid risk and improve healing. So they are an important aspect of providing proper patient care. So effective discharge planning can reduce the likelihood of being readmitted to the hospital, so as well as aid in rehabilitation. So this ensures drugs are ordered and administered correctly and properly prepare the patient and the significant others. So for the medication, we need to provide an accurate list of medication to the patient or to the significant others. Then instruct patient to follow the prescribed medication and the proper drug dosage, time route, frequency, and storage before releasing them to reduce the potential side effects or errors when providing medication to the patient. The next is we need to explain the potential side and adverse effect, contraindication, and cautions of the prescribed medications to reduce risk of complications. Then we need to discuss the purpose of the prescribed medications to expand the knowledge of the patient and the significant others. Then instruct patients and significant others to not stop taking the medications on their own since medications adherence is important. So it is best to talk with the healthcare provider before doing so. Then lastly, we need to encourage them to refill prescriptions before running out of medicine and have a talk with the healthcare provider if there's a problem with the cost of medicines. Then let's proceed to the exercise. So for the exercise, we need to encourage the patient to do exercise on a regular basis, if not contraindicated. This is to ensure healthy, active well-being. Then advise patient to do deep breathing exercise. Encourage the patient to find activities that he enjoys, like taking a walk and a day for at least 30 minutes. Then instruct the patient to avoid performing high-impact exercise or heavy lifting. Then remind to remove any objects that can cause trips, bumps, falls, etc. So before doing any of these activities. Then explain the significance and advantage of regular exercise in one's health and instruct to stop activity if the patient gets symptoms such as chest pain, lightheadedness, or shortness of breath. Then for the treatment, advise the patient to continue taking the prescriptions. This is done to alleviate or manage symptoms as well as enable the patient to live a more comfortable life. Instruct patient to inhale through their nose while their mouth closed while receiving oxygen via nasal cannula to acquire the maximum amount of oxygen needed by their body. Then discuss about the safety precautions regarding the use of oxygen to the significant others. Encourage the patient to comply with all the treatment prescribed by the physicians and also follow-up checkups. Then instruct to monitor change in heart rate, pulse, blood pressure, and weight. Then encourage the significant others to keep the environment clean and well ventilated. So this is for continuous airflow and oxygen. Then for the hygiene, promote good hand hygiene practices for patient X and their caregivers, especially before and after handling the patient, so using bathroom and before eating. Then provide guidance on self-care practices and maintaining a clean and safe environment to prevent infection and discomfort. Then for outpatient or for the checkup, we need to emphasize the importance of attending scheduled follow-up appointments with the healthcare provider to monitor progress and adjust treatment as needed. Then discuss typical post-discharge expectation and signs that may require medical attention. Then for his diet, we need to encourage the patient to follow the DASH diet, which emphasizes the consumption of foods on low in sodium, low fat dairy products, whole grains, plenty of fruits and vegetables. So while limiting intake of energy, dense sugar and processed foods. Then encourage the patient to do regular exercise like walking to maintain a healthy lifestyle. Then for the spirituality or emotionally, we need to inspire the patient to do a simple form of prayer and encourage her to do it regularly. Then encourage the patient to practice spirituality because it ultimately builds resilience and coping skills to help a person consistently take actions and make decisions that support better heart failure management. So that's it for my report. Thank you.